Hi, as Jonathan said, I've been asked to come along and speak about an audit we did in Western Bartonshire looking at high dose opioid prescribing. So I'm just going to take you through some of the reasons we did the high dose opioid audit, what we were looking for and really what the results of it were. Okay. We did the opioid audit January to March 2012 and it was in all the practices in Western Bartonshire. Why did we do it? Well, there was quite a lot of discussion in the press, the general press and the medical press about the problems associated with opioids. This is an article in The Independent and it was in November 2011 and it was speaking about addiction fears with opioids and that we should have tighter monitoring of opioid prescribing. This is an article in one of the American medical journals and it was talking about long-term side effects of opioids and how we don't really know what the risks associated with opioids are. We don't know what the addiction potential is really, and there's a link between the strength of opioid that you're using and the risk associated with it. So what they were saying in this paper is basically if someone's on an opioid, you should really be monitoring that it's going to be effective when you're using it. 1 in 7 of the population in Scotland are associated to have pain. So we did a search looking at the PRISMS information, which is prescribing information across Glasgow. And this graph just shows you the number of items that have been dispensed across Greater Glasgow and Clyde Health Board. We looked at a few different things. If you see the top purple line, that's the number of fentanyl patches that had gone out between March, April 2010 to July 2012. So you can see it's kind of rising and then it starts to dip roughly around about April, May 2011. We had an indicator at the prescribing team that was looking at fentanyl prescribing and changing it to possibly marchafene. So I don't know whether that's been something that's caused a reduction in the fentanyl prescribing or not. It's hard to say. The other things we've got there are the morphine prescribing. Morphine's the opioid of choice in Glasgow, so we expect that to be quite high. The next one we've got is the oxycodone, and you can see the oxycodone has been rising slightly over the last 2 years, which we kind of hope to use morphine first line before we be trying oxycodone. The bottom line is buprenorphine patches, and it's quite a flat graph. It's non-SMC approved, so we'd rather not have as much buprenorphine patch prescribing as possible. So that's pretty good that it's the lowest out of them all and it's flat. As I said, I'd rather it was kind of reducing, but we're working on that. So if you are going to be prescribing high dose opioids, then the Glasgow guidelines recommend that you would use an evidence-based intervention first before you try the opioid. So for example, if the patient's got neuropathic pain, you'd be thinking about using the amitriptyline or gabapentin first line before you tried the high dose opioid. Also, if you're going on to put them on a high dose opioid, you should really be replacing all the step 2 opioids with step 3. So stopping their cocodamols and their tramadols and replacing that with morphine, etc. But keep them on their non-opioid analgesics. So if they're on paracetamol, keep them on that, or if it's appropriate for them to be on an NSAID, then keep them on that as well. And the guidelines recommend that people who are on high dose opioids should be reviewed regularly, at least every 6 months. So that's something that we're looking at when we're doing the West of Scotland guidelines as well. It's probably quite important that you're discussing with your patients when you're starting them on an opioid what their expectations of their pain relief is, because you'll not get complete pain relief usually with opioids. So it's important that patients understand that, and probably the goals of therapy are more to get an improvement in their function and their social and their emotional function. And an effective kind of opioid trial would be a 30% reduction in the visual analog scale, so that would suggest it would be successful. What drugs did we look at? We looked at oxycodone 60 milligrams a day or more, transdermal buprenorphine 70 micrograms, or 50 micrograms of transdermal fentanyl. And we discussed at the MCN, the Glasgow MCN, what was going to be our standard for the audit, and we reckoned that about 75% of people who are on high dose opioids should really have seen their pain specialist within the last 12 months or be in the process of being referred to the pain specialist. So what do? We were a team of 4 pharmacists and 4 technicians. We went into all 18 practices in Western Berkshire, which had a combined practice list of 97,000, and we started doing the audits between January and completed them all in March 2012. This is quite a busy slide, but these are the results that we actually found. It's quite difficult sometimes to actually extract the information from the patient's notes. As I said, we had a tool that we went in and pulled out all those patients who were on those drugs that I spoke about earlier, and we looked physically at the notes, and sometimes it was difficult to see where the drugs had been initiated or how frequently they were being changed. Sometimes the patient's life seemed quite chaotic, and quite often they DNA'd for appointments, so it's quite difficult for the GPs to actually find out whether the patients the opioids were effective in these patients. So we had 133 patients in total who were on high dose opioids. 9 patients had cancer. Don't know if that's what you'd expect or not. I was probably quite surprised. I probably thought there would be more patients with cancer out of the high dose opioid patients. From the patients who we could see where the drug had been started, 61 had been started in secondary care, 44 had been started in primary care. But you might find it's interesting if you look at the fentanyl, 15 patients had been started in secondary care there, and 16 had actually been started in primary care. Again, don't know why that is, but it's interesting to note. There were 82 patients who had been reviewed in the last 6 months, and there were 36 who had been reviewed in the previous 12 months by the pain clinics. There were also 27 patients who were on an additional step 2 opioid. So basically, we had 0.1% of the population in Western Berkshire who were on high dose opioids. We didn't really know how many people we'd have before we did the audit, so that was quite useful. The range across the practices was from slightly less than 0.1% to 0.3%. Most of the practices were at the 0.1% level. There was probably one practice who was at the 0.3%, and they were quite, by far, outliers. So they are now looking at their opioid prescribing to see why they are such high outliers. So 93% of the patients had non-malignant pain that they were getting their opioids for, and 29% had met the standard of being reviewed by secondary care in the last 12 months. But that's not the full picture. There were 46 patients who had been reviewed in secondary care by other specialists, for example neurology or rheumatology, or they had been reviewed by their GP. So it's not as bad a picture as you maybe think from if you saw the results. So just to compare the standard again, the standard was 75% of patients should have had their opioids reviewed in the last 12 months by the pain specialist if it was more than 120 milligrams or more of morphine, and we had 29% who were seeing the pain clinics. So there's quite a few kind of questions thrown up by the audit, which went on to inform the development of the West of Scotland pain guidelines, and things like, what are the review processes within primary and secondary care for patients on high dose opioids? What criteria should be applied to patients on high dose opioids to prompt referral to secondary care? Should high dose opioids ever be initiated in primary care? Might be a bit contentious, but that's one of the questions that was asked. Should primary care be reviewing patients on high dose opioids to assess if patients can be appropriately reduced, and if so, are there guidance on how to do this? And what should happen with patients on high dose opioids who fail to attend for review? And that's the end of my talk.